Imagine a future where surgery is so precise, recovery is faster, and outcomes are dramatically better. What if the most delicate procedures were handled not by human hands, but by incredibly accurate robotic systems? Get ready to explore how cutting-edge robotic surgeons are revolutionizing patient care and shaping the future of medicine right now. Picture an operating room. It is clean, sterile, and filled with advanced technology. For centuries, the art of surgery has been defined by the skill, steadiness, and experience of the human hand. But even the most skilled hands can tremble, and traditional laparoscopy gives a limited field of view. The quest to overcome those limits began decades ago. DARPA, NASA, early prototypes, and the first robotic arms. Pioneers like the Arthrobot and the Puma 560 showed robotic precision could enter the operating room. First orthopedic and neurosurgical uses in the 1980s. In 2001, the Lindbergh operation proved remote surgery was possible. A cholecystectomy performed across an ocean. Systems progressed. ESOP, Zeus, and then the Da Vinci platform, which integrated console, patient-side cart, and vision into one workflow. Today, Intuitive Surgical's Da Vinci systems number over 10,600 globally, with roughly 17 million procedures performed to date. But what exactly is inside a robotic surgical system, and how does it make those gains in precision? Let's deconstruct the machine. It's part console, part patient-side robot, part vision system. Next, the Mech Maestro in action. A typical system has three core components: the surgeon's console, the patient-side cart, and the vision cart. At the console, the surgeon sits a few feet away, viewing a high-definition stereoscopic 3D image and manipulating master controls. At the table, the patient-side cart holds several slender robotic arms that enter through small ports. A high-definition endoscope provides a magnified 3D view, sometimes up to 10x, essential for depth perception. Robotic instruments use wristed articulation, 7 degrees of freedom, letting tips rotate and bend beyond the human wrist. Software scales movements and filters tremor. A 1-inch hand motion can become a 1/4-inch action at the tip. That steadiness allows delicate dissection and suturing in tight anatomical spaces that are otherwise hard to access. While Da Vinci dominates with more than 10,600 units in 17 million cases, challengers like Medtronic's Hugo, CMR's Versius, and Senhance are diversifying the market. A single Da Vinci can cost up to $2.5 million, with annual maintenance of roughly $150,000 to $200,000. Reusable and proprietary instruments, plus disposables, raise per-procedure costs. Historical estimates put instrument cost around $1,800 to $2,000 per case. Robotic platforms are digital. They generate huge datasets. AI can analyze video and telemetry to improve performance and training. Imagine AI highlighting nerves or vessels in real time, or suggesting optimal dissection planes during surgery. We've already seen narrow steps toward autonomy. Robots like Star can perform supervised suturing tasks, but full autonomy remains a complex challenge. Robotic surgery changes the surgeon's physical workload. Seated ergonomics reduce fatigue and musculoskeletal strain. Less fatigue can translate into sustained concentration during long, complex cases. Next, the benefits patients actually feel, from smaller scars to faster recoveries. For patients, the main worries are pain, scars, time away from life, and complications. Robotic-assisted techniques use small incisions rather than large openings, dramatically reducing trauma. Smaller incisions mean less pain, smaller scars, and often a reduced need for strong narcotics. Prostatectomy. Robotic surgery typically reduces blood loss and shortens hospital stay versus open surgery. Hysterectomy, similarly less blood loss, fewer conversions to open surgery, and often faster recovery. Hernia and colorectal cases show lower conversion rates and shorter stays, though operative time may be longer. In select cardiac procedures, robotic approaches reduce wound infection and shorten ICU time. Evidence is nuanced. Robotic surgery shows clear gains over open surgery, compared to conventional laparoscopy. Outcomes are often comparable. Important caveat, many published benefits come from high-volume centers. Learning curves vary. For example, prostatectomy proficiency may require 100 to 300 cases. Some colorectal programs reach proficiency in 25 to 30 cases. Patient stories vary. Many report same-day discharge and rapid return to activity, while complications and rare mechanical failures do occur. Shorter hospital stays, often 1 to 2 nights instead of a week, and earlier return to normal life are frequently reported. Magnified 3D vision and precise cauterization frequently reduce intraoperative blood loss and transfusion needs. Small discrete scars can have a major psychological benefit for many patients. So yes, robotic surgery can improve tangible patient experiences, but context matters. Surgeon skill, case volume, and system costs shape real-world outcomes. Next, we address hard questions: cost, access, workforce impact, and the evolving role of the surgeon. Some fear robots will replace surgeons. That misunderstands the technology. Robots are tools, executing the surgeon's movements. The surgeon remains the decision-maker, strategist, and safety overseer. When anatomy surprises us or complications arise, human judgment and improvisation are irreplaceable. Cost is the major barrier. Purchasing, maintenance, and proprietary instrument fees can make robotic programs expensive. Upfront, up to $2.5 million. Annual service, $150,000 to $200,000. Instruments, hundreds to thousands per case. These numbers shape hospital decisions. Consequently, robotic surgery is concentrated in major urban centers, creating geographic disparities in access. A patient's zip code can influence their access to robotic options, a major equity concern. Training is essential. Modern curricula use simulations, wet labs, proctoring, and progressive clinical exposure. See one, do one, teach one. Simulators build skill, then trainees move to supervised or cases with proctors. Proficiency varies by procedure. Some require dozens, others hundreds of cases to match top outcomes. Team learning also matters. Marketing pressure can push hospitals to adopt robots to attract patients, which complicates the clinical evidence equation. Hospitals must balance patient benefit with return on investment and caseload to amortize costs. New entrants, modular carts, lower-cost platforms, and competition should drive prices down and increase access over time. The best outcomes occur when highly experienced surgeons use advanced tools. The robot enhances, it does not replace, wisdom. Regulation, credentialing, and ethical oversight must keep pace with technology to protect patients. Training, proctoring, and standardization help ensure safety. The human touch remains central. The next wave is AI, miniaturization, telesurgery, and greater connectivity, turning robots into intelligent partners. Surgical data science uses video and telemetry to find patterns, improve efficiency, and create personalized training. Imagine overlays that highlight nerves and vessels in real time, helping surgeons avoid injury. Miniaturization could bring needle-sized robots or swallowable capsules that perform internal biopsies without incisions. Microbots could deliver drugs or perform cell-level interventions, changing how we treat tumors and repair nerves. These ideas are experimental today, but they point to a future of truly non-invasive intervention. Telesurgery, the original dream, becomes more feasible with ultra-low latency networks like 5G. A specialist in a city could operate on a patient in a remote clinic, bridging medical deserts. This also revives military and disaster response use cases for forward surgical care. If made affordable and maintainable, robotic surgery could democratize complex care. But infrastructure and supply chains are critical. Training local teams and ensuring maintenance capacity is as important as the robots themselves. Policymakers must weigh costs, outcomes, and equity to avoid creating two-tiered systems of care. The path forward requires bold innovation, careful oversight, and a commitment to make benefits available to all. Imagine a world where the best surgical skills are no longer limited by geography or wealth. A future where your chances of a successful outcome are not determined by where you live. A future where human expertise and machine precision heal together.